My name is Ben Osman. I am a third-year student nurse, and this is my presentation for module PRNA 3101. The title of this presentation is A Critical Analysis of the Complex Adult Health and Social Care Needs of an Adult Health Service User. Now I will introduce you to my patient. Ben is 62 years old and has been an inpatient for a few weeks. He has several different needs, all of which pose challenges to me as a newly qualified nurse, as this is a very complex case. His physical needs are: he needs treatment for a UTI, he needs diabetes management, his sacral ulcer, which is slow to heal, needs managing. He is suffering with malnutrition and he needs to be assessed and treated for this. His poor appetite needs to be reversed and mitigated. His blood glucose levels need to be controlled. He is prescribed hypoglycemics and insulin twice a day, and this needs to be better managed. He has limited mobility and a lack of independence, and he is a left lower leg amputee and wheelchair user. His mental needs are poor compliance. This needs to be addressed and overcome. He has a history of manic depressive mood swings and is experiencing periods of frustration and agitation. Ben needs help to curtail this. He prefers to be left alone, which suggests he's becoming more reclusive. He is refusing medications and becoming abusive to staff and becoming forgetful. His social needs are that he is on disability benefits. He lives with his sister in a ground floor living space in a converted dining room. He has enough space for a single bed, wheelchair and TV with bathroom access. His sister works full-time and is not his full-time carer, but she can only take him to afternoon appointments. Due to Ben's comorbidities and lack of medication and treatment concordance, this is going to be a very difficult and challenging situation to manage and evaluate, but it is a challenge I'm looking forward to. Here is my introduction. In this presentation, I will identify Ben's physical, psychological and social care needs, as well as the needs of his family. I will separate two care needs and explore them in detail. I will identify policies and laws that govern my practice, identify and explore literature that informs my decision making, allowing me to deliver safe and effective care. I will reflect on the challenges as a newly qualified nurse looking after Ben. I will demonstrate literature that informs my practice, and I will critically analyse, evaluate, explore and reflect. I have chosen to separate, focus and analyse the treatment and management of Ben's sacral ulcer and his prospective safe discharge home. My main area of prior expertise is within community hospitals, having worked for the NHS since 2014 and nursing homes before that. I have taken part in the safe discharge of many patients while on placement. I have experience with many patients who are living with sacral ulcers, and due to the complexities in this scenario, I have opted to focus on challenges that I have encountered in my prior practice. Both of these subject areas are subjects that I am interested in and positive about. I am looking forward to improving my knowledge around sacral ulcers to enable me to deliver safe, more effective care to my patients. Ben's safe discharge can be hastened with effective management of his ulcer, and this has been my experience while working with patients who have these things wrong with them. Now I will discuss clinical decisions and care management. The NICE 2020 guidelines stipulate that a risk assessment tool is used and carried out to assess the likelihood of them developing pressure damage. NICE recommends nurses implement the Waterlow assessment tool. According to Sharalambu et al. 2018, prevention is the ideal strategy to tackle the problem of pressure ulcers. I will begin to manage Ben's sacral ulcer by first using the Waterlow assessment tool to determine his risk of further damage. The Waterlow assessment tool is a number-based tool. 10 to 14 indicates a patient who is at risk. A score of 15 to 19 indicates high risk, and a score of 20 and above indicates very high risk. The Waterlow tool is universally recognised, so it can be used cross agencies. The benefit to Ben is the continuity of his care and the prevention and management of his ulcer. This tool helps nurses to determine whether Ben needs pressure-relieving equipment such as air mattresses or pressure cushions. The Waterlow consists of 7 parameters: build and weight, height, visual assessment of the skin, sex, age, continence or incontinence, mobility, appetite, and special risk factors divided into tissue malnutrition, neurological deficit, major surgery or trauma, and medication. However, critical analysis of the Waterlow assessment tool highlights that it doesn't focus on any future treatment of ulcers, rather focusing on prevention of further damage. It's focused on prevention rather than treatment. Whilst Ben is an inpatient, it is important that the SSKIN bundle is kept up to date and accurate. According to Whitlock 2013, the development and use of a skin care bundle to delivering fundamental care in practice is now a recommended and effective way of transferring research into practice by offering consistent care with resulting positive outcomes for the patient. A skincare bundle consists of a small number of interventions for every patient to whom the bundle is applied. The skin bundle methodology has been developed to facilitate consistency in practice. The theory behind the implementation of a bundle approach is that the whole is likely to be more effective than the sum of the parts. For example, when carrying out a skin bundle, it has several parameters such as surface, skin inspection, movement, incontinence, and nutrition. Bringing these together simplifies and provides a succinct account of a patient's welfare, enabling me to assess whether Ben is at risk of developing further damage. In ulcer prevention, any patient identified as being at risk of ulcer development in every practice setting, including the community, should be placed on a pressure ulcer prevention care bundle. This enables me to assess, evaluate and plan Ben's care by bringing together information regarding several factors related to his tissue viability and the risk factors. Intrinsic factors, such as Ben's diabetes, can contribute towards a slow healing of ulcerated wounds. This is usually down to loss of feeling, also known as neuropathy, caused by nerve damage related to diabetes. I base my critical analysis of the Waterlow and skin bundle on the ease of use, effectiveness and collaborative advantages. As identified in quantitative research by Sharalambu et al. 2018, the Waterlow assessment tool has a low rate of consistency when 236 nurses produced in total 941 assessments. The Waterlow assessment had an agreement rate of 20%. This means that the results of the Waterlow assessment tool can vary dependent on one nurse's interpretation compared to another's. This is a relatively large body of research and therefore gives nurses a good gauge of its accuracy. The Waterlow assessment tool allows the assumption of stability in the individual's condition, which can be difficult to achieve as a patient's at risk for ulcer development condition can change quickly. McCulloch 2016 explains that identification of an ulcer earlier ensures easier treatment. In this case, Ben has already developed an ulcer. However, part of the skin bundle relates to repositioning of a patient. Providing Ben is compliant with this, nurses can enable that pressure relief is delivered and documented, thus lowering the chance of further damage to his sacrum. Also, the skin bundle is completed 24 hours a day and by many different members of staff, meaning that changes in Ben's position can be documented accurately. Laverly et al. 2019 collected data for 462 resident bed days prior to implementing the bundle during during which 5 new pressure ulcers were recorded, and repositioning was the only documented pressure ulcer prevention behaviour. Data was collected for 1,181 resident bed days during the intervention phase. No new pressure ulcers developed, and the documentation prevention parameters consisted of those contained within the NHS skin bundle. Participants reported that the bundle enhanced the care they delivered. Both Whitlock 2013 and Laverly et al. 2019 found that skin care bundles directly contributed to better practice and patient outcomes. In Ben's case, he has made nurses aware that he prefers to be left alone. So the challenge with using the skin bundle is that staff would have to prompt him to reposition if he hadn't already done so. This potentially could be a cause for conflict between Ben and staff, as he has previously become agitated and aggressive. However, given that Ben's ulcer is slow to heal, in my opinion, the reward warrants the risk, because the results that Whitlock 2013 and Laverly et al. 2019 observed were largely positive for patients. The World Health Organization, also known as the WHO, is a specialized agency of the United Nations responsible for international public health. The WHO formulates guidance and world policies for healthcare organizations globally. The WHO 2010 suggests that wheelchairs are one of the most commonly used assistive devices for enhancing personal mobility. According to Stockton and Parker 2002, pressure ulcers are common with those living in wheelchairs. This relates to Ben, as he is living with a wheelchair. Moving on to the EPUAP. The EPUAP is a European-based advisory group that develops practice for health services all over Europe. They do this by carrying out and critiquing research from healthcare providers across the continent. Here, I have opted to employ a strategy recommended by the EPUAP, which is a system based on photographs. A photo would be taken with Ben's consent. This achieves 2 benefits. Firstly, it enables multidisciplinary teams to view the wound and apply a classification. Secondly, it is a visual aid. The size, depth, colour and appearance of Ben's ulcer can be documented, and at a later date, progress or regression in healing can be observed and documented. It also serves as a tool to measure whether any prospective treatment has had any effect. According to local NHS policy 2019 Trust Withheld, all pressure ulcers are to be categorised using the EPUAP pressure grading chart. DeFleur and Schoonhoven 2004 conducted research to assess the effectiveness and accuracy of photos being used to classify ulcers. 56 photographs of ulcers were shown to 44 pressure ulcer experts. The only difficulty in clarifying wounds in this study was between grade 2 ulcers and moisture lesions. Assessing an ulcer via a photograph doesn't enable a professional to grasp accurately the depth or the feel and texture of the skin surface. This data must be interpreted with caution, because the sample size is quite small. Also, it is only based on what is in the photo. No details regarding the patient's age is given, and the results don't rule out the possibility that the pressure ulcer experts may have been able to confer with one another, thus influencing the results. Also, pressure ulcer care is ever evolving, and this research was carried out in 2004, meaning that results may be outdated. However, these results were used to help develop the EPUAP classification guide for pressure ulcers that is still in use today. Next, I would carry out a root cause analysis. My local NHS trust has a zero tolerance policy to hospital-acquired pressure ulcers. Therefore, a root cause analysis can help determine when it was developed by auditing all of Ben's prior documentation. National NHS policy dictates that a root cause analysis must be carried out for any incident, in this case, the development of Ben's sacral ulcer. According to Greenwood and McGuinness 2016, Malnutrition was found to be the single biggest contributing factor when carrying out a study monitoring ulcer healing timescales in an inpatient setting. Bearing in mind that Ben suffers with malnutrition, this is a useful tool as it enables me as a nurse to interpret which comorbidities are having the biggest effects on slowing tissue healing and potentially delaying his discharge. However, a more comprehensive study may focus on one age group, particularly patients in the over 60s, given that Ben's over 60. Next, I will refer Ben to the tissue viability nurse. As a newly qualified nurse, my knowledge and experience of pressure ulcers is likely to be less in-depth than other healthcare professionals. It is important that in adhering to the NMC Code 2018 Section 13, that I recognise and work within the limits of my competence. I make a timely referral to another practitioner when any action, care, treatment is required. Furthermore, I ask for help from a suitably qualified and experienced professional to carry out any action or procedure that is beyond the limits of my competence. In this situation, I feel Ben would only receive optimal care if I refer his care to other professionals. Without specialist assistance and collaboration, it will be difficult for me to plan the care of Ben's ulcer. An appropriate grading of Ben's ulcer enables me to manage Ben's treatment appropriately. Tissue viability nurses, also known as TVNs, can deliver education to enable better patient outcomes. Evidence from Law 2003 strongly suggests that collaborating with TVNs can directly improve my knowledge as a nurse delivering pressure ulcer care. Law 2003 carried out a study with the aim of measuring the knowledge nurses had regarding pressure ulcers. Within this study, 38 nurses took part in TVN-developed education. Before the nurses took part in a pre-course ulcer knowledge test. The results averaged at 27.2, compared to 84.2 after the course was completed. The study concluded that after the TVNs had delivered education to nurses, that the nursing knowledge levels increased considerably and the number of pressure ulcers in this setting vastly decreased. Educating Ben and his family regarding the best treatment plan for his ulcer means he can make an informed decision regarding his care. For example, it may be recommended that Ben should have a dressing applied to his sacral wound, and by educating him and his family on the benefits and potential adverse effects of this, a more informed decision can be made. According to Bale 1995, there were 5 key skills of TVNs, including establishing an accurate diagnosis, making sure the treatment plan is practical and up to date for those delivering the care, in this case me, objectively monitoring the effectiveness of care, liaising with other healthcare professionals and facilitating effective levels of care and arranging an appropriate follow-up care plan. Communicating with Ben and his family also ensures that as a nurse I provide person-centred care and base care around Ben's wishes, advocating for his needs in this situation. This ensures that I adhere to the NMC Code 2018 Section 2, which states that nurses listen to people and respond to their preferences and concerns. Also, encourage and empower people to share in decisions about their treatment and care. And this is what I'm aiming to do for Ben. Ben has several comorbidities, namely, he is living with diabetes. Diabetes puts patients at risk of further tissue damage and can slow the healing of ulcerated tissue. Also, he is suffering from malnutrition, which according to Jewell et al. 2018 can put patients who are living with ulcers at risk of a delayed recovery. This can lead to Ben remaining in hospital for an extended period of time. due to complications. Referring Ben to a TVN adheres to NICE 2020 guidelines, which stipulates that any adult who is assessed as being at risk of developing a pressure ulcer needs to be assessed by a trained healthcare professional. Given that tissue viability nurses' experience is more valid in this situation, I feel that Ben would benefit from their input. Now I will look into how I will form a collaborative approach into managing Ben's care. Once Ben has been deemed medically fit for discharge by the ward doctors, planning for his discharge can commence. An MDT, multidisciplinary team, meeting can bring together professionals and relatives to advocate, plan, and assess the needs for a patient. Professionals such as nurses, doctors, dietitian, occupational therapists, physiotherapists, social workers, and district nurses, and potentially home carers. For this scenario, I have mainly explored tissue viability nurses. However, I will briefly explain why Ben would benefit from a social worker's input. Ndoro 2014 states that the benefits of MDT working is that professionals will be more familiar with one another's specialties and roles, thereby improving interprofessional communication. Professionals will improve collaborative working, thereby improving high-quality care. Professionals will gain broader repertoires of knowledge and skills, thereby increasing Ben's access to care. Adult social workers need to assess Ben's home situation to see if it is safe for him and feasible to return. The main challenge here is, it is likely that Ben will be returning home in a different state than when he left. The social workers can collaborate and open a dialogue with Ben's sister to decide whether managing his care at home will be practicable to herself, Ben, and any potential care agency providing Ben with a package of care. Social workers can maintain contact with Ben and his sister post-discharge to monitor if there are any changes. If that was the case, they can help Ben access other services and resources to ensure he stays safe. Social workers can also help Ben access any state funding or state-funded care. The Care Act 2014, Section 9, legislates that where it appears to a local authority that an adult may have needs for care and support, the authority must assess A, whether the adult does have needs for care and support, and B, if the adult does, what those needs are. This relates to Ben because having referred him to social workers, he will be under the monitoring and care of the local authority, who can help him access benefits and funding. In an MDT meeting, as well as discussing Ben's ulcer care management and social situation, all of Ben's other care needs can be discussed, along with the risk assessments and best practice. One example would be on how Ben would manage his diabetes at home. Another factor I have taken into consideration at this point is that Ben's compliance with his care can be poor at times. This makes managing the safe care and treatment of a sacral ulcer more challenging, but trying to develop a good relationship with Ben and his family by educating and keeping an open dialogue can help by establishing what Ben wants to achieve post-discharge. Allowing his sister to take part in the MDT meeting gives Ben an advocate in the meeting. It also means that she can have a clear understanding of the expectations post-discharge. Here is a brief overview of other referrals, considering that his pressure ulcer isn't the only consideration here. A dietitian referral can enable Ben to receive support to overcome his malnutrition stemming from poor appetite. Occupational therapists can assess Ben's mobility and how he plans to mobilize and carry out daily tasks once he is at home. They can also assess whether Ben would be safe while at home. Ben has a history of manic depressive mood swings, therefore a referral to the mental health team can lead to Ben receiving care and treatment for this. Ben has not been managing his diabetes effectively, therefore a referral to a diabetic nurse specialist can help Ben achieve a satisfactory management of this disease. A referral to the community and district nursing team can provide Ben with a safeguard whilst at home. They can arrange home visits to assess and manage the healing of Ben's wound post-discharge. Given that Ben is a left lower leg amputee and wheelchair user, we can surmise that his mobility is hindered. Physiotherapists can help Ben to maintain or improve mobility by working with him to improve standing and walking techniques. Now I will reflect and conclude. I feel that I have achieved the potential for Ben's sacral ulcer to be managed well in line with policies, legislation and best practice methods. However, I have realised that my approach relies heavily on the knowledge and input of the TVN. Moving forward and in practice, I'd like to become more autonomous in relation to managing ulcers. I recognise that I have prioritised Ben's physical and social needs over his psychological needs. However, from further reading, in practice I realise that this may not be as practical as his mental health may be hindering his care compliance. I feel that I have been both reactive and proactive in managing Ben's ulcer. In completing the Waterlow assessment, I have potentially safeguarded Ben from further skin ulceration, and I have reacted to the wound by an MDT involvement to treat it. My research in this presentation was focused mainly on Ben's sacral ulcer, and I feel that wider reading and research regarding his other care needs would have benefited my practice and Ben. As a newly qualified nurse, I have learnt that keeping up with research and legislation allows me to deliver and manage safe and effective care to patients. Keeping up to date with best available evidence enables I continue to practice within the NMC code. Finally, I recognise that MDT working helped me to do all I can to enable a safe discharge for Ben and his sister.